ACPMP Symposium for the Huntsman Cancer Institute. It's great to have everybody here and great to see you joining us. And I just want to introduce Dr. Erin Ward, who's one of the surgical oncologists here at the Huntsman Cancer Institute, who is a HIPEC surgeon and is also really doing a lot of research in appendix cancer. And so we're going to hear from her about some of the research efforts that are going on here as well. And also, we're going to share with you some exciting things that we're looking forward to in the future here at the Huntsman Cancer Institute. But one of the traditions that I have had since I've been doing these symposia with the ACPMP Research Foundation, something that I think is incredibly valuable and my favorite part of the day, is to hear from you, from patients and their families, people who are actually dealing with appendix cancer and who've either had surgery or not, are in different parts of the journey with this type of cancer, and to hear from them and their experience. Again, a huge part of the ACPMP mission is to provide support to patients and their families who are dealing with this rare, often confusing and sometimes very challenging disease. And so today, Dr. Ward and I have invited two very special ladies to join us. We have Nancy Sutliff and Janet Hawes, who have both had cytoreductive surgery and HIPEC. And what's very unique about them, one very unique thing about both of them, is that they're both in their 80s when they had the surgery. And so we often hear, Dr. Ward and I often hear from patients about whether they're too old to have the surgery. There are some surgeons who won't operate on people past a certain age, regardless of how healthy and physically fit they are. And so we wanted to allow Nancy and Janet to share their experiences with you. Both very inspiring. So Dr. Ward, did you have anything else that you wanted to add at this point?
No, just a big thanks to Nancy and Janet for joining us and being willing to share kind of your experience. I don't know if we want to start with Nancy. I mean, if you're Nancy and I go way back now, a couple years. Nancy, we'd love to hear about kind of your journey, both, leading up to it, finding out the diagnosis, and kind of your experience during the surgery and after.
Well, before everything, how I found out about it was I fell off of a table, changing a light bulb, and cracked a rib. I had to do an X-ray and CT, and they found a mass. And so my primary doctor sent me to find out what was going on. And I ended up that they were going to remove my appendix. They decided the mass was my appendix. So I had a surgeon go in, and he said he peeled off my appendix off of my ovary because it was stuck there and had been probably there for a while. Anyway, so I did that, and then I found I had a fistula in one of my bowels. So I was going to go in for surgery for that and have my ovaries removed at the time because there was no sense in keeping them at my age. And I ended up that the doctor opened me up and said, "Oh, she has PMP. I know, I've seen it. I know what it is." So I was referred to an oncologist in Boise, and after talking to the oncologist and finding out about PMP, which was quite a journey, and yes, I'm very emotional about it still because it was quite a journey, and I found out about HIPEC, and I was like, wow, what about it? But it was looking at my age, and I was like, not sure about that. So I went ahead, and my pharmacist actually told me, he says, "Don't you want to know? Don't you want to help somebody else? And even at your age, don't you want to help somebody else?" And I said, yes. So I asked my oncologist up here to refer me to Huntsman, which was the best decision I have ever made in my life. So I went to Huntsman, met this wonderful Dr. Ward, and that was our journey. That began the whole thing. And what I did was I did the surgery. I did not know until actually yesterday all that was happening to me. That's why I'm a little emotional about it. But I was ready to leave the hospital. I had had my shower. I was ready to go. I was great. Surgery was easy peasy for me. Dr. Ward had a problem, but she took care of me wonderfully. So I went ahead, took my shower, and then I crashed. Come to find out, I had sepsis. And let me tell you, even though it was that journey of going through sepsis and everything, if somebody said to me at my age or whatever age, you have this disease, I would take it in a minute. I'd go for surgery. I would have it because afterwards I have my life back. I can, yes, I go every once in a while for my CT scan and my blood test to find out I don't have cancer, thank God. But it's wonderful. It's wonderful. And I can take care of my family and my pets and my granddaughter.
Mhm.
And my granddaughter has leukemia. So I love her to death and take care of her. And I look at the fact that with this disease, you can have the surgery, you can have the HIPEC, you can take care of it. But with leukemia, you're on chemo day after day after day. And I'm here for her. The end.
No, that was very moving. Thank you so much for sharing your experience. It was really a pleasure taking care of you. And it's been great to get to know you more and more over the years. Yeah, I mean, I think, as you highlighted, there were some ups and downs, and, that's part of why we really advocate for people to go to the higher volume centers where we know how to help you kind of navigate that, and we're ready to help take care of you before, during, and after.
Yeah, I've done this last month before, I actually got on a plane again, flew to Northern California and watched one of my saw my great grandkids, saw my grandson get married. So one of my grandsons. So that was the highlight.
No, means a lot. That's great.
You can live your life, people, afterwards. Very definitely. It is wonderful.
Great. Well, thank you, Nancy. So Janet, so you and I have history together too, and maybe you can tell your story about how you got diagnosed, how we met, and your experience with the surgery as well.
I had a CT scan in August of 2023, and the scan showed that I had that problem. My son-in-law, who is a doctor at another hospital, he talked to his surgeon colleagues, and they said, well, you need to go see Dr. Laura Lambert. And so I got on the phone and was able to get an appointment with her. And through our conversations, she talked about this surgery. And I'm all for it. I would do it again. It was a little bit difficult. I had abdominal surgery in the past with cancer, and I was able to kind of know what I would be getting into as far as the surgery, but I just have to say that I had very little pain. I was able to get back to doing things when I got home from the hospital. And I just am so grateful that I was put in contact with Dr. Lambert and that she had the expertise to help me.
Well, thank you. And are you willing to share a little bit about what happened in the middle of your hospitalization with the person sitting next to you?
I don't know that I told him about it. Yeah, I had one night when I was hallucinating, and it was not a pleasant experience. I'd never done that before, so it was kind of a frightening experience at the time.
Yeah, no, that is actually a very common thing. So it is something that we counsel people, especially people who are older, if they're going to have a big surgery and having a lot of different medications and anesthesia and pain and in an unusual environment, not sleeping well. That's a very common thing that we see. And that can probably be one of the most hard things for patients' families to actually see. Sometimes the patients don't necessarily recognize that it's happening. But it's very hard for their families. They're worried, has the person had a stroke? Is this going to be permanent? You know, is this revealing something else that they didn't know was going on? And so that's always challenging, but that was brief and you recovered completely from it. But you also had you and your husband had another challenge during while you were in the hospital. If you remember, he ended up in the hospital himself.
He did. On the way home from the hospital after my surgery, he was hit by an impaired driver, and he ended up in another hospital in the ICU with a broken vertebrae. So he had to wear a collar for 6 weeks.
Mhm.
So between the two of us, there were some things that we just couldn't do.
Yeah,
So we had the help with our children.
yeah.
So good to
Yeah.
come in.
I think that really also speaks to, some of the other things we talked about earlier in the symposium about how helpful it is to have support like that. I know you had a wonderful support network. That was a really tough challenge for both of you to go through at the same time. I remember when you told me that the next day, what had happened. It was the night of your surgery that happened. And just so
Yes.
grateful that both of you did well and recovered from all of that. So, yeah.
Me too.
Yeah. Great. Is there anything else that either of you would share with the audience? Anything I see some family members, anything that family members would share from their perspective about?
Your family member.
Hi, my name is Casey. I am Nancy's granddaughter. From a family's perspective, when she was first diagnosed, there was hesitation, of her age coming from her. And I just looked at her and I said, Grandma, either you're going to live your life, with the disease, and who knows what that's going to look like or how short-term that's going to be, or you're going to give the surgery a fighting chance and you're going to be able to live your life again. And here she is, 83 years old.
82, please.
82.
I'm not there yet.
She might put me in the hospital for that one, but she's her and Janet both are just a walking testament to giving that surgery a go.
Great. Thank you. Dr. Ward, how do you, like, when you are meeting somebody who's a little bit older, how do you, what made you think that it would be a good idea to recommend the surgery to Nancy?
Yeah, I think, some of the things that were highlighted was how active she was. She talked about walking a mile on her treadmill, so I'll never forget that. That means a lot. It means someone is actively maintaining their health, right? Motivated to maintain it, have found ways to integrate exercise even when it's cold, right? And snowy outside. And then the amazing support system she brought in. And that was clearly available to her because the reality is every surgery is going to have its ups and downs. And sometimes things go perfect and sometimes even when they go perfect, you need somebody to help support you after. And, even that comes to going to the grocery store or meal prep or, making sure you make it to those follow-up appointments, having that extra resource. So those are the things that really stood out.
Mm-hmm. Great. Yeah, I would echo all of that. I know when I met Janet, it was I'll be honest with you, when you see somebody on your clinic schedule in their 80s, you're first looking through to see, do they have a lot of other medical problems, right? That might make it difficult for them to get through a big surgery. As with anybody else, you're also looking to make sure that this is a tumor that you would normally offer surgery for, and the heated chemotherapy. You're looking at their scans. Do you think you can get all the tumor out? And then when you actually meet the person, it's exactly what Dr. Ward said. How physically active is the person? What support systems do they have? What are their goals, right? That's the other thing. And I think, Janet, we talked a lot about that. What are your goals? What is the recovery going to look like? And does that, does that make sense to go through a big surgery, like depending on what your goals are at that point in your life? And so it is very individualized. There's no question about that. And but I think what both these wonderful ladies that clearly demonstrate is that for the right person who's fit enough and has the appropriate tumor type that we can technically remove the disease, that it's a reasonable thing to consider. And I don't personally think that age alone should be a contraindication. I think you need to take a holistic approach to this. You need to look at everything about the person, about the disease, and see if it makes sense for that individual.
Dr. Lambert, my mom, can I read something that my mom wrote that I'm
Yeah,
just,
absolutely, please,
Okay.
yeah.
so my mom, Nancy's daughter, she kind of recapped yesterday something for her, and I'm just reading it on the table, and I think it's worth reading on her behalf. So our mom and PMP, so had a history on January 26, 2023, she had a hysterectomy, splenectomy, gallbladder removed, bladder had to be opened up and reclosed. We'll have catheter for 7 days. They had to open bladder and close, 2 bowel resections, colostomy, lining under both diaphragms, omentum removed, 90 minutes internal hot chemotherapy, all of this at 80 years of age. After 45 days in Huntsman, at the Huntsman Center with Dr. Aaron Ward, at the helm, she was released to go home and recuperate before her reconnecting surgery of her temporary elastomy bag. It was definitely a long and bumpy journey, but on July 13th, 2023, she was able to have her elastomy reversal surgery done. She is one of the strongest, determined ladies we know. Who would have thought what was in store for us when she fell off that kitchen table, changing a light bulb? Thank you to all of those doctors, nurses, and the rest of the hospital staff for your care and support.
Thank you. Thank you for reading that. I guess the lesson here is stay off the table.
I almost went on the other day.
Wonderful. Well, thank you both for coming on and sharing your stories. And
Guys.
I'm sure it's been inspirational to the people who have been listening, and just grateful for you guys being willing to come and share your experiences with us.
We thank you for all that you do. We really do.
We do. I just would like to say that I was so grateful for the staff in the hospital. They were wonderful. The care I received was fantastic. So I would recommend Huntsman to anyone, and the doctors and staff. It was just a good experience.
Yes.
Oh, good. I'm glad to hear that. Thank you. Thank you, Janet. Thank you, Nancy.
Thank you.
All right. I'm going to turn this over now to Dr. Ward, who's going to give us an update on some of the research that we're doing here.
So we already kind of just brief outline. Janet and Nancy already shared their stories with us. So we're going to talk a little bit about advancement and management of appendiceal cancer. We'll talk a little bit more about the decision regret study, some projects here at the Huntsman, and then I'll turn it over to Dr. Lambert, and she'll talk a little bit more about a study she did about optimizing pain management here, PIPAC, and then we'll hand it over to Deb to talk a little bit about the ACPMP patient registry. Big thanks to Nancy and Janet for sharing their stories today. So advancements in appendiceal cancer management. So, a lot of what we're doing, is obviously taking care of patients, but also trying to improve the journey. And there's a couple key parts of that we've been focusing on, that we continue to focus on. Obviously, those who were at the general session, we've heard a lot about all the different ways that we're approaching improving how we diagnose and treat and care for patients. But I'll talk a little bit more about patient selection, optimizing treatment and the surgery, and then improving post-operative care. So, as we talked about, patient selection is about more than just a number. It's about, I think as we talked about, it's more about activity than age in some ways. It's about, evaluating how somebody is interacting with their daily world. It's about making sure that we have identified patients who we can optimize their comorbidities. So even if you do come with some other conditions, heart problems, lung problems, if we can take the time to make sure we optimize those comorbidities, then, we can better set you up for success after surgery. And then in general, a concept that we often employ here is prehabilitation. So that's essentially where we ask, identify where patients are at prior to thinking about surgery, and then try to set them up to make sure that they continue to thrive leading up to surgery. So that can be asking patients to interact with either our physical therapist, or just start a at-home exercise program where they improve their or increase their exercise tolerance. It can be trying to optimize nutrition leading up to surgery. So some of the ways that we're improving our outcomes for patients who are undergoing these large operations for appendix cancer is really about thinking about not only who we're offering the surgery to and making sure we're doing the best job of picking the right patient who's going to do well with this surgery, but also about setting every patient up to be successful. So when it comes to optimizing treatment and surgery, one of the things that we're doing to try to make sure that we're having the best outcomes for all patients is being thoughtful about for treatment sequencing. As we talked about in the general session, there is a range of different types of appendix tumors or cancers. And for some of these, surgery alone with HIPEC is the best treatment, and there's no reason to consider chemotherapy. And for others, thinking about doing chemotherapy up front versus after surgery, and just being thoughtful about multidisciplinary care, meaning involving our medical oncologists, both the local medical oncologists as well as some of our medical oncologists at the cancer centers, to weigh in on what's the best approach for you as the individual. The other thing that we do is we really protocolize everything, meaning that we have spent a long time trying to figure out what are the best ways to get you set up for surgery. So we have you meet our anesthesiologist. We, try to prevent dehydration leading up to the surgery. And then in the operating room, we have protocols for our anesthesiologist, how much fluids we give. All these little things end up mattering and contributing to better management when it comes to both surgery as well as how you do as the individual. And then, as Janet and Nancy mentioned, this is a team sport. So here at the Huntsman, our nurses and our respiratory therapists and our nutritionists and our pharmacists are all very used to taking care of patients who have had this big operation, as well as our anesthesiologists. So having a big group of people who are committed to taking care of this disease and helping our patients after surgery really is helping us optimize outcomes for patients. And then, as was also referenced, I think the best way to optimize care at this point is really going to high volume centers where you're not going to be the first appendix cancer they've seen, and you're not going to be the first person who undergoes such a large operation. So those are kind of the ways that we're moving things forward and the management and improving patients' outcomes. And then another big part of it is the post-surgical support. So again, just referencing that this is a multidisciplinary effort. So even when you go home, we're still working on nutrition. We're still working with our outpatient nutritionist to continue the support that you got in the hospital. Obviously, sometimes people are traveling far to get their treatment. So a lot of times this can have, impacts financially. So we've got financial counselors here and at most cancer centers who can help navigate, whether it's getting FMLA for family members or navigating insurance. And then psychosocial support. So obviously granddaughters can support us in many ways, whether that's helping us getting on Zoom calls or helping us go on those walks or getting those meals or going grocery shopping and beyond. So what we know anecdotally, meaning we know from experience, is that social support is really important. We also know that how the patients are doing when it comes to their mental health is really important. So all of these ups and downs of chemo or surgery can take a toll, and having that social support and being willing to talk about those hard times can help us make sure that we're getting you guys the best care you need. And then physical therapy and like we said, social support. And then the other thing we're doing is we're improving our surveillance. There was reference to this earlier, but we use both the tumor markers that I think most of us are familiar with, the standard ones like CEA and CA-125, but then we're also integrating new and modern ones like the circulating tumor DNA where appropriate to make sure that between this and the CT scans that we're keeping track of if the disease comes back and where it comes back and being thoughtful about what to do next. And then being up to date on all the trials that are going on throughout the country and making sure that we're connecting you guys to those trials if we don't have them here and trying to create trials ourselves here. Next, I just wanted to talk a little bit more about the decision regret study because we kind of helped participate in this. A big thanks to Dr. Alyssa Greenbaum from the University of New Mexico, who's a great surgical oncologist over there who's taking care of patients with appendix cancer. So this was her study and concept, but she really wanted to get to the root of how patients looked back on their experience from after having cytoreduction and HIPEC. So decision regret is just in general, a patient's distress or regret having over a healthcare decision. So this has been studied in other more common cancers. So it's great that Dr. Greenbaum took the time to ask patients who've had this large operation to see what was their experience. So they really wanted to understand how patients with appendix cancer report regret after having a cytoreduction HIPEC procedure and understand if complications or the other things that impacted their rates of decision regret. So Dr. Lambert kind of mentioned this study earlier, but this was an anonymous survey sent to the ACPMP members, and a big thanks for all of those who participated and replied to this survey. They wanted to look at the age, demographics, surgical outcomes, disease details, decision regret, and other symptoms that may interact with decision regret. So GI symptoms, pain, anxiety, fatigue. 122 of you guys responded. The average age was 51. 78% of us, the patients were female. And 52% had a low-grade appendiceal mucinous neoplasm. And then about a quarter had an appendiceal adenocarcinoma. So overall, a very small percentage reported decision regret after having this operation, and 86% reported no decision regret. When they looked at what impacted the rates of decision regret, overall, again, only 14% reported decision regret. They specifically looked at those who had complications within 30 days of surgery, and rates of decision regret were much higher among these patients, up to 55%. And those who had a hospital length of stay that was greater than 30 days had higher rates of decision regret, and those with a new ostomy also had higher rates of reported decision regret. But overall, the rates were very low. And as what was highlighted earlier, when they looked at all of these variables together, the big ones that seemed to make the biggest impact was those who had the new ostomy had a much higher rate of decision regret, and those with persistent GI symptoms had higher rates of decision regret. And finally, when they looked at those other symptoms or the patients with decision regret were more likely to report higher rates of pain, depression, lower rates of physical function, meaning their ability to do daily tasks, lower rates of saying that they could interact with social roles or activities, higher rates of fatigue, anxiety, and sleep disturbances. So all kinds of things, all kinds of symptoms that you would, if they were still persistent, you would imagine may lead to more decision regret. But yeah, overall, there was very low rates of decision regret among the patients, even after this big operation, and those with complications or new ostomies seem to have higher rates of regret. I think lastly, I'll just kind of touch base on some of the studies that we're doing here or working on. at the Huntsman Cancer Institute. So one of the studies I've been working on for a while that's about to start recruiting is primarily aimed at trying to introduce mindfulness prior to surgery and then after surgery. There have been previous studies here done in the orthopedic population, so those undergoing elective surgeries for their knees, who've had the opportunity to watch a guided mindfulness meditation video right before surgery. And after these one-time video intervention, patients who were offered this intervention had lower rates of pain, higher rates of physical function. So I am hopeful to introduce this for patients undergoing cytoreduction HIPEC soon as a way to hopefully further improve outcomes. So we'll be comparing how patients do with or without the intervention, and also see if expressive writing, which is essentially another way of journaling, but the journal prompts are very specific to what you guys are going through. So thinking about like prior to surgery, how are you feeling about surgery? How are you feeling about your diagnosis? Things like that. And both of these interventions have been shown to be effective at mediating pain and improving outcomes in other surgery types. So Dr. Lambert has also been actively working on an existential distress study. So trying to understand how we can improve patients' experiences for those who aren't offered surgery because of one thing or another. So she's been working closely with our psychology department to try to offer patients who have identified higher levels of existential distress to be offered a ketamine infusion to see if we can improve those symptoms. And further, we're also going to be starting to integrate patient-reported outcomes so we can better understand your guys' experience prior to surgery, after surgery, and then throughout your surveillance. And then finally, similar to some of the stuff that was presented at the general symposium, we're working with some of our basic scientists that exist here at the Huntsman to try to better define appendix tumors with RNA analysis. We're also trying to better understand how circulating tumor DNA, which is again a blood test to see if there are DNA consistent with your tumor is floating in your bloodstream, if that's going to benefit all patients who undergo cytoreduction HIPEC who have appendix cancer, or if we can better figure out who will best benefit from being followed with this. And finally, we're trying to better understand how fibroblast or cells that make scar tissue may impact our ability to truly remove all the tumor. So I'll kind of hand this over back to Dr. Laura Lambert to talk a little bit about her pain management study, PIPAC, and then finally Deb to talk about the patient registry.
Great, thank you, Dr. Ward. And there's a lot of stuff going on. It's been really wonderful to have Dr. Ward join our practice here, and with a little bit of a critical mass, we're actually able to start really doing some research and advancing patient care and management. All right. So I'd love to just share a little bit about this study that we did. Anybody who's had cytoreductive surgery and HIPEC here recently may have experienced what we call the on-cue catheters. So I think one of the big things that people worry about when they're facing a surgery like this is pain. So we often get asked that question: how much pain do I expect after the surgery? And it's obviously a concern for us as well. We want to make sure that pain is well managed because if it is not, people don't take deep breaths. They might get a pneumonia. They're not getting up and walking around, and we worry that they'll get a blood clot in their legs that can then cause a problem. So there are a lot of reasons to manage people's pain, not only because it's better. People don't feel well when they're having a lot of pain, but also for these other physiologic reasons. So we take this very seriously. And originally when I started doing HIPEC, I was frequently or essentially always using epidural catheters as a way of managing people's pain after the surgery. And some of you may be familiar with that. They're very frequently used for women who are delivering babies to block the pain, but allowing them to still have motor function so they can participate in the delivery. And we can also use that approach for managing post-operative pain so that people can still get up and walk around, but their pain is blocked so they can cough and take deep breaths and they don't get blood clots and they don't get pneumonias. And I was a big fan of that approach. And then after a couple of years here at the Huntsman, there was a new technique that was becoming available called the On-Q catheter, which are these tiny little tubes that you can put underneath the skin on either side of the incision, and they just bathe the incision in a numbing medicine to help block that pain. So it's a similar approach to the epidural, but the procedure is less invasive, less scary to people to hear about having a catheter stuck in your spine, and less labor intensive. So when we put in epidurals, we have to rely on anesthesiologists to manage those for us. They usually stop working at 2 o'clock in the morning when there's nobody available to help take care of them. So then people get stuck and they have pain, and for a while before somebody can come and fix the problem. And so we were looking for that was a good alternative. We were looking for a better alternative. And at the same time, more recently, people have been starting to use a drug that might have a bit of a bad connotation associated with it called methadone. You know, a lot of people associate that with people who are trying to overcome a substance use disorder. But it's actually a good pain medication as well. It's long acting. It lasts for about 48 hours. So we and our anesthesiologists were willing to use it. So we started using that and the On-Q catheters at about the same time. And so we decided to take a look and see. My experience was when we made that switch that pain was much better controlled. They were going home using a lot fewer opioid pain medications, and they were leaving the hospital earlier. There were other benefits too, where people were getting up and moving around more quickly. We could get the bladder catheters out more quickly. So a lot of benefits seem to be coming out of that. So we wanted to look and see if the data supported what we thought we were observing. So we did a study where we went back and we looked, this kind of just goes over what I just said, where we went over and looked through all the patients that we had operated on from January of 2018 to January of 2022. And we collected all their information about them, went through all the records, and then looked at how long they stayed in the hospital, how much pain medication they used of different types, and then looked at whether they got the On-Q with the methadone or whether they got the epidural. And we wanted to see if they were equivalent or one was better than the other. And so what we basically found was that we had operated on 130 patients over that time. And then we divided them. We only looked at patients that had cytoreduction and HIPEC, and this included patients that didn't have appendiceal cancer. So this was more specifically for that technique. And what we found was that there were 111 patients who had either the epidural or the On-Q or methadone. 40 patients had the epidural, and 71 patients had the On-Q, these little catheters, and the methadone. And we went back and we looked through all the technical details about how much medication they received. And then we looked to see how this panned out. And basically what we found was that the average age in the two groups was in the 50s, so 51 for the epidural, 58 for the On-Q and methadone. So no statistically significant difference in that. 60% of the patients in the epidural group were male, 52% in the On-Q methadone group were male. So again, no statistically significant difference. And the length of surgery was roughly the same in both groups. So these are important data to look at because you want to make sure that the two groups that you're comparing are roughly similar in characteristics that may or may not impact the outcome that you're studying. And we also looked at the different types of cancer that people had. And you can see the vast majority had the lamin. The next largest group had appendiceal cancers, and then there were a handful of others: colorectal, mesothelioma, primary peritoneal, and some ovarian cancers. So this is relevant. I present that because this is relevant to this group that's listening. And what we found was that the patients who got the OnQ and the methadone were out of the hospital a day sooner than the patients that got an epidural. Now, that might not sound like a big deal, but if you expand that or extrapolate that across everybody having cytoreduction and HIPEC and everybody having one less day in the hospital, that actually adds up to a lot in terms of resources being used and cost for the hospital stay. And in addition, if anybody has been in the hospital after having this surgery, I think a day really is clinically significant as well. People want to get home. And as I always tell people, there's a difference between wanting to get home and being ready to get home. And I don't let anybody go home until they're ready to go home. And that is based on what the person and their family are telling us. And to be able to get out of the hospital a day earlier, I think is a huge advantage. And then when we also looked at how much of the opioid type of pain medication that people were using in the two groups, that they needed in the two groups to maintain their pain at the appropriate level, we saw that there was a significant decrease in the patients who had the OnQ and the methadone. So a lot less use of opioids, and I'm sure everybody's aware of the opioid epidemic that we're facing in this country and the risk of people getting addicted to these medications. So anything we can do to decrease a person needing opioid analgesics to help take care of their pain after surgery, we are looking for ways to do that, to try to just mitigate those possible adverse side effects. And then another drug that we commonly use to help people with pain after surgery is a drug called ketamine. And Dr. Ward mentioned that in a different context, but it's also helpful for managing people's pain. And we saw a significantly less use of this drug ketamine in patients that had the OnQ and the methadone compared to the epidural. And similarly, this is just another way of looking at the opioid use on a day-to-day basis. And basically what this equated to was this is 30 morphine milliequivalents per day, or about 4 tablets of oxycodone per day, less use in the patients that got the OnQ and the methadone versus the epidural. So basically what we concluded from our study was that using the OnQ and the methadone is safe for cytoreductive surgery and HIPEC, which is important because we're giving chemotherapy. That's a unique aspect of the surgery. It's a big incision, and pain is a significant factor that we have to address in helping people get through this surgery. And there were no adverse effects from either one. Some of the concerns, anytime you're leaving a catheter in, is could it get infected? We didn't see any problems with that. And also people worry about the methadone, if that can have an effect on people, either their cognitive function or their respiratory function. And we didn't see any adverse side effects with the use of that in this context. Again, it was associated with a decreased length of stay, decreased opioid use, and decreased use of that drug ketamine. And that we really feel like we're hoping that this is a way forward, that other institutions will look to this as an option to start using, to also start helping people get out of the hospital sooner, improving their pain management, and relying less on the opioids. So we were really excited about the findings of that study, and it has become our approach to pain management here. I think it's been incredibly helpful and successful. And I know Dr. Ward's doing the same thing, and I think she feels the same way about this approach as well. And the other item that she had on her list that I just wanted to briefly talk about, because we do want to hand over some time to Deb Shelton from the ACPMP Foundation to talk about the patient registry. But something that's been coming up more and more frequently is the use of PIPAC. I did talk about that briefly this morning. That is the use of what we call pressurized intraperitoneal aerosolized chemotherapy. So this is a surgery that's done laparoscopically or minimally invasively is what we talk about, where we're literally aerosolizing the chemotherapy and injecting it into the abdominal cavity under a very high pressure, which allows it to penetrate into the tissue and into the tumor at a much higher concentration. Currently, this approach is reserved for people who have cancer such that it can't be removed completely with surgery, such that the heated chemotherapy washing would be effective. And as I mentioned earlier today, it's in the US, it's currently mostly being done under the auspices of a clinical trial. It's a multi-institutional clinical trial centered out of the city of Hope in California, but also taking place in Jacksonville, Florida, and at Northwell in Long Island in New York. And the reason why I'm bringing it up is I just want to let people know that I recently got certified in this approach. Dr. Ward is going to be getting certified, and we're really hoping to bring it to the Huntsman Cancer Institute and to collaborate with the City of Hope doing some clinical trials, as well as bringing it to patients from this region so they don't have to travel. So stay tuned for that, where there's a lot of logistics and some hurdles that we have to get through, but we're very optimistic that this is going to be a part of the future of treating appendiceal cancer. And the hope is that for people who may not be candidates right now for cytoreduction HIPEC, that the efficacy of PIPAC will bring it so that we will be able to get some people to cytoreduction and HIPEC. So stay tuned for that. And I do want to give some time to Deborah from ACPMP. So thank you very much for your attention, and we'll turn it over to Deborah.
Okay, thank you. I want to be sure that you all have time for Q&A, so I'll try to be very, very brief. But first, Nancy and Janet, really appreciated both your stories. Never too old. I'm a caregiver to my elderly mom, who at 83 at the time was diagnosed with a different type of cancer. And I remember all too well shopping for a surgeon that would take us on, and me constantly prepping her up and making her look beautiful as she is, so that doctors would realize she was a good candidate. Anyway, tonight we celebrate her 87th birthday, cancer-free. So the patient registry, long story short, for those of you that don't know, what a patient registry is essentially a collection of data. In this case, it's a collection of patient experience data, appendiceal cancer patient data. And the purpose of it is really to help drive research. What it is we are working with the National Organization for Rare Disorders, goes by the acronym NORD. They have a great I Am Rare platform that is open to members that we're using. Dr. Ward has been hugely helpful in getting this across the finish line. We're finalizing it now. We hope to launch it certainly by the end of the year. And it's very simple. It is separated out into 5 different modules. It's all electronic. The patient or their legal representative would go into the data room and basically just answer the questions electronically. And then all of that data will be collected and be put in a major research repository that all researchers interested in furthering research on appendix cancer will be able to access. The data will be de-identified. There's going to be no kind of specific identifiers of data to patient. So no concerns about that. And basically, soup to nuts, these modules are going to look at things like demographic data, where did you grow up? Did you live close to a farm? Were you on well water? Or were you a smoker, a drinker? Kind of life questions like that. Then through Diagnostic Odyssey, what were your symptoms? What did that look like? What was your treatment? What is your post-treatment? And then there's a final module on things like quality of life and payer-related issues. So really covering a broad swath of topics, so that regardless of what topic a researcher is interested in, they can access that data. Super important I'm a former FDA regulatory lawyer myself. I worked for 30 years on the drug development side. FDA does this whole patient-focused drug development. I cannot tell you the number of times that they've asked for a patient-driven data to complement the data that the pharmaceutical companies are doing. So I'm really excited about this. I really hope that we can move this forward. We're going to need as many people as we can to input their data. The more data, the richer the database, the more progress hopefully we can all make. Stay tuned if anyone's interested that's not on our mailing list to keep up with ACPMP, patient registry, other stuff that we're doing. You can please email me at info@acpmp.org. And if you are on our mailing list, you'll be getting information about this as soon as it launches. And we'll also have it on our website. I hope that's all clear. I meant to say never too old to get braces either. After a life of orthodontia problems for my retirement gift to myself last year, I got braces and I just switched into a new tray, as I call it. So it's very hard for me to talk. So I apologize, but thank you both for letting me plug the patient registry. And Dr. Ward, thanks for all your help with it. Dr. Lambert, thanks for all your help with everything that ACPMP does.
Oh, my pleasure. Thank you guys for all that you do. So Deborah, before you disappear, there was a question in the chat that I answered, but I just want to make sure I answered it correctly. You accept patients in the registry from anywhere on the globe, right? Doesn't matter where they live.
Correct. That's correct.
That's what I assumed. Great. All right. Well, we're at it's 2:30 here in Utah, but 4:30 on the East Coast. Are there any other questions from the audience? There were a couple in the chat that I think I answered, but or any final words from Nancy or Janet or their family, Dr. Ward? Anybody? Nancy? Oh,
Sorry, my sound keeps going off. I apologize. No questions. This is awesome. Thank you.
Great. Okay. It does look like there's a couple questions coming up. Somebody who's still having pain 5 weeks after surgery. I think, well, I think everybody is a little bit different, and it can depend on, how much surgery you had, if you've had previous surgery, whether you were on pain medications before the surgery. All these things can impact your experience with pain, how well your pain was controlled right after the surgery. Some people form more scar tissue than others, and that can cause discomfort after the surgery. You really need to work closely with your surgeon, whoever's managing your pain, obviously we also want to make sure that there isn't something wrong, right? So sometimes pain getting worse after the surgery weeks out can be a sign of a complication or something. So you just want to make sure your surgeon's aware of that, and then figure out whether it's within the norm, what's to be expected, or if it's concerning, and work with that person to help address the pain. And it should fade after a while, and everybody's going to be a little bit different. 5 weeks is still very, very early after the surgery. Not surprised if somebody still has pain at 5 weeks after the surgery. Dr. Ward, any other thoughts on that?
No, I would just echo what you said is, I think it's always good to get some reassurance from your surgeon, because I think it's hard to sit at home wondering if something's normal or abnormal. I will say it does take, I would say most people say 6 weeks is usually a turning point where I see people start feeling better, but people often still have fatigue and some discomfort, and sometimes that discomfort comes and goes up to 3 months. And I think 3 months is where I really see people kind of start perking up. And that's just because it's a big operation, but yeah, I would just echo what you said, that sometimes it's very normal, but it's always good to get reassurance so you don't have to think about it, worry the whole time.
Yep. And then there's another question about PIPAC for Lamin and the location of where the tumors are. So that is that's an area that is still sort of being investigated. I think most people would recommend, if the person is a candidate for cytoreduction and HIPEC, that would be the #1 choice. And the PIPAC is being reserved for people in whom that's not really an option. So that would be very dependent on each individual circumstance. But if somebody is not a candidate for cytoreduction and HIPEC and they're fit enough, they can certainly might be considered a candidate for the PIPAC. But that, again, would have to be reviewed by a surgeon who's familiar with doing PIPAC and the indications for it. So hard to just answer that without seeing more details. Great. Let's see some more questions. As some advice, make sure you get up and walk around after HIPEC even when you don't feel like it. Absolutely, that's incredibly important to prevent blood clots, prevent pneumonias, and just get you feeling better. Honestly, even if you don't want to, I think that's really important. Let's see. It's another person who unfortunately didn't have post-surgical support and is having a lot of gastrointestinal problems. I think if you're not having any support from the surgical team, reaching out to your primary care doctor. If you don't have a medical oncologist, well, if you have a medical oncologist, reaching out to them, and then maybe they can talk to the surgical team. If you don't have a medical oncologist, reaching out to your primary care doctor and maybe getting plugged in with a medical oncologist. Also, nutritionists are very helpful. Gastroenterologists can be very helpful. Palliative care can be very helpful as well. And palliative care isn't just about hospice or transitioning to not getting care directed towards your cancer or your tumor. The palliative care physicians can also help with just symptom management. So it would be very appropriate to have a palliative care consult after a surgery like this if you're still having symptoms that are not being well managed, because they often have a lot of additional suggestions to make around helping with those things. Erin, anything else that you can think of?
No, I would just echo everything that you said. I will say that a lot of patients struggle to gain weight those first couple weeks after surgery, so timing is a lot of it. So again, some of these things if you when you come and talk to us about it, sometimes we'll say, yep, we kind of expect those, and sometimes we don't. Timing is a lot of it. But I agree with all the resources that you listed as other opportunities to get help.
Yeah, I usually typically advise or inform people that we expect you to lose, after the surgery, we expect people to lose weight. 10, 15, even 20 pounds is not unusual. And I tell people that because I don't want them or their family to get nervous and think that that's a complication from the surgery. We expect that. It usually takes a couple of months for the weight to start coming back up. And also that's about the time when people start to feel their energy coming back. When you're still losing weight and your body's demanding a lot of calories to recover from the surgery and you can't eat enough to maintain that, you're going to feel tired. That's where the fatigue comes from. But once your body starts demanding less calories just to heal from the surgery, and those calories can go to you putting on weight and gaining energy and strength, that's when you'll see that starting to come back. And that's usually sometime around 8 to 12 weeks after the surgery. And that's what the literature would bear out to. There's no question there's a dip in people's quality of life in the first 3 months after cytoreduction and HIPEC, but then ultimately by 6 months, we expect people to be back to their baseline, if not a little bit better, especially if they were having symptoms prior to the surgery with the HIPEC. So hang in there. It does get better. And, please, feel free to reach out to us if you need support after the surgery, if there's anything that we can do to help. Other HIPEC centers are also, I'm sure, willing to help and support people with the recovery from this as well. So I do think we're over time, and I know everybody has, it's been a long day, but it's been full of a lot of great, helpful information. We're so appreciative of your attendance. We're so appreciative of Nancy and Janet, again, and their family, helping them come on. We're indebted to the ACPMP Research Foundation for making an event like this possible, and just letting you know that that you're not alone, that there's a lot of support out there. I'm grateful just want to thank Dr. Ward, my partner, for joining us here at the Huntsman and joining us around the symposium today. It's been great to work with her. She's a tremendous surgeon and physician, and we're just excited about the direction that things are going here at the Huntsman Cancer Institute. So thank you, everybody, and I hope you have a great weekend.